Welcome to the Deep Dive. We're here to take complex information, break it down, and make it really stick so you can feel genuinely informed fast.
Exactly. Think of it as clearing away the clutter, getting straight to the core knowledge you need.
And today, we're diving into something really important for many of you listening. Certified Professional in Healthcare Quality, or CPHQ, revision.
That's right. We've put together a pretty solid list of CPHQ-style multiple-choice questions. Our aim isn't just, ticking off the right answer.
No, not at all.
We really want to dig into the why behind them, the actual healthcare quality principles they represent. So you walk away with a hopefully deeper grasp of it all.
Absolutely. And this deep dive, it's specifically for you, the learner. Maybe you're studying for the exam right now. Maybe you just want to sharpen your quality knowledge. Or maybe you're just someone who likes to really get how things work in healthcare quality. We know you like things clear, efficient, and you appreciate those aha moments when it all clicks. So we're aiming to give you exactly that clear links, key takeaways.
And we'll be your guides today. You've got, well, someone who genuinely gets enthusiastic about figuring things out and making dense topics interesting.
I try.
And then there's me bringing maybe a more analytical viewpoint, helping to connect the dots and think critically about the implications.
Sounds like a good team. So let's jump right in. First question up. The following represents an essential element to an effective quality counsel. A, consultation of the legal advisor. B, direction from the organization's quality department. C, participation of the strategic planning committee. D, involvement of leadership. Okay, looking at those, what really stands out is essential.
Well, they all sound potentially useful, right? But essential. I'd have to go with D, involvement of leadership.
Okay, D, involvement of leadership. Let's really unpack that.
Yeah.
Why is having leadership at the table so fundamentally crucial for a quality council to actually, work effectively?
Well, think about what a quality council needs to do. It needs to drive change, implement initiatives, get resources.
Right. It needs clout.
Exactly. Clout. And where does that ultimately come from in an organization?
It comes from the top. Leadership involvement, it signals that quality isn't just some side project or, a departmental thing.
It's a strategic priority.
It's a strategic priority. Their active participation means the council's work gets taken seriously. Recommendations are more likely to get the funding, the staffing, the organizational push needed to actually happen across different areas.
Yeah, I can see that. If leadership isn't visibly backing it, things can just fizzle out, right?
Absolutely. You've probably seen it. When leaders are truly engaged, attending meetings, asking tough questions, holding people accountable for quality metrics, it sends a powerful message. It empowers the council.
Okay, so that makes sense why D is the most essential. What about the others? Like the legal advisor or the quality department, aren't they important too?
Oh, they're definitely important, but more as supporting players, maybe. Consulting legal A is vital for specific risks, compliance issues, potential litigation, but it's not the core driver of the council's existence or overall effectiveness.
Okay. And direction from the quality department. Yes, that's crucial for expertise, data, methodology, but the quality department often reports to leadership. They provide the engine, maybe, but leadership holds the steering wheel and the keys.
Gotcha. And the strategic planning committee.
Linking with strategic planning is smart, yeah. It helps align quality goals with the organization's broader objectives. But again, if leadership isn't involved in the quality council itself, that link might not have enough weight. The other roles support, but leadership enables. It's foundational.
Foundational.
Yeah.
Good word for it. Okay, let's move to the next one. Question 2. For a community hospital, patient satisfaction scores demonstrate multiple areas needed for improvement, including a need to improve attractiveness of the facility, responsiveness to patient needs, and physician and nursing communication. Based on these results, which of the following would the healthcare quality professional also will be expected to find? The options are A, departments are operating independently with little communication between units. B, administration is prioritizing and leading units to achieve organizational goals. C, departments managers are openly discuss patient satisfaction scores. D, employee satisfaction scores in the 90th percentile compared to other peer organizations. So we've got low scores on looks, responsiveness, and communication. What underlying issue likely connects these?
Okay. Low scores across the board like that. Facility appearance, responsiveness, and communication. That paints a picture of some systemic issues, doesn't it?
Yeah, it doesn't sound like one isolated problem.
No. And when you see issues like poor responsiveness and poor communication specifically, my first thought goes to how different parts of the hospital are working together, or maybe not working together.
Ah, so you're leaning towards A, departments operating independently, little communication.
I think that's the most likely culprit, yes. Think about the patient journey. It cuts across so many departments, right? Admissions, nursing units, diagnostics, pharmacy, discharge planning, environmental
Right,
services.
it's complex.
Super complex.
Yeah.
And if those departments are essentially functioning as separate kingdoms with weak handoffs and poor information sharing, well, responsiveness is going to suffer. Things fall through the cracks.
Maybe the nurse puts in a request, but the environmental services doesn't get it promptly, so the room isn't cleaned, impacting the attractiveness.
Exactly. Or the physician makes a decision, but it's not clearly communicated to the nurse, or the nurse's concerns aren't effectively relayed back. Boom, communication breakdown. Patient feels lost or ignored.
And responsiveness tanks.
Precisely. Poor interdepartmental communication is often a root cause for exactly these kinds of patient complaints, feeling ignored, delays, conflicting information. The facility attractiveness could even tie in if, say, maintenance and housekeeping aren't coordinated well.
Okay, that makes a strong case for A. Why are the other options less likely given these specific patient complaints?
Right.
B, admin prioritizing goals.
Well, if administration was effectively prioritizing and leading units, B, you'd expect better coordination and probably higher satisfaction scores, not these widespread problems. It suggests a lack of effective leadership or alignment, actually.
Right. And C, managers openly discussing the scores.
If managers were openly discussing these poor scores, C, that would imply they're aware and hopefully working on solutions. While that might be happening, the existence of these problems suggests the discussion, if it's happening, hasn't led to effective fixes yet. It doesn't quite fit as the expected finding based only on the low scores themselves.
Okay. And D, high employee satisfaction.
High employee satisfaction, D, alongside these patient issues. It's possible, maybe. Sometimes staff are happy within their own silo, even if the overall system isn't working well for patients. But it's not the most direct or expected consequence of poor responsiveness and communication. Option A, the lack of coordination, just feels like a much more direct explanation for the specific pattern of complaints.
It connects the dots more clearly. All right, let's switch to something quantitative. Question 3. Dental Department's monthly case review revealed 240 records meeting criteria, and 150 records did not meet the criteria. In calculating the incidence rate, the denominator is A90B, 390C, 240D, 150. Okay, calculating a rate, the denominator, what's the rule here?
Right, the denominator is the bottom number in a fraction, the total population or group we're looking at. In this case, we're doing a case review. We looked at a certain number of records.
Some met the criteria, some didn't.
Exactly. So the denominator for any rate calculated from this specific review needs to be the total number of records reviewed.
Okay, so we just add them up, the ones that met and the ones that didn't.
Yep. Simple as that for this context. We have 240 that met criteria plus 150 that didn't. So 240 plus 150, that's 390.
390 total records reviewed. So the denominator is 390, that's option B.
Spot on. It's B. The denominator represents the entire group under consideration for that specific calculation.
Now, the question uses the term incidence rate. Does that change anything here? Or is it just asking for the denominator in this specific review context? And maybe, can you quickly clarify incidence versus prevalence? That sometimes trips people up.
Good question. In the strictest epidemiological sense, incidence rate usually refers to new cases developing in a population over a period of time, often with person time as the denominator.
Okay.
However, in quality improvement and case reviews like this, the term rate is sometimes used more broadly to mean a proportion, like the rate of records not meeting criteria within this reviewed batch.
Ah, so it's context dependent.
Very much so. For this specific question, regardless of the label incidence rate, the denominator is clearly the total number reviewed, 390.
Got it. And the incidence versus prevalence difference.
Right. So incidence is about new occurrences. Think of it like the flow of water into a bathtub. How many new cases of flu appeared this week? That's incidence.
Okay.
New cases. Prevalence is about existing cases at a point in time or over a period. How many people have diabetes right now? That's prevalence. It's like the total amount of water in the bathtub at a given moment.
New flow versus total volume.
Exactly. Incidentally, new cases over time. Prevalence is total existing cases at a point in time. In our dental review, we weren't really tracking new failures over time in a population. We were looking at the proportion of failures within the snapshot of records we reviewed. So 150/390 would be the proportion, or rate in this context, of records not meeting criteria in that review.
That clarifies things nicely. Thanks. Okay, moving on. Question 4. Research, quality assessment, and quality improvement. A. Use scientific methods to test hypotheses and statistical methods to analyze data. B. Are considered protocols rather than projects. C. Do not share the aspect of systematic investigation. D. Do not require documentation of IRB approval before publication. What's the common thread linking these three research, QA and QA?
Interesting comparison. They definitely have overlaps and differences, but the strongest commonality, I'd say, is A. They all, to varying degrees, rely on scientific methods and use statistical analysis.
Okay, expand on that. How does a QI use scientific methods? It feels less formal than research sometimes.
It often is less formal, sure. Formal research sets out with rigorous protocols, controls, aims to generate generalizable new knowledge. Think randomized controlled trials.
Right.
Quality assessment, QA, is about measuring performance against a standard. It uses data collection and analysis, often statistical, to see where things stand. Are we meeting the benchmark for infection rates?
Measuring and monitoring.
Exactly. And quality improvement, QI. While it might not always involve a formal hypothesis in the research sense, it definitely uses a systematic, data-driven approach. Think Plan-Do Study Act cycles.
DSA cycles.
You'll plan a change. That's kind of like your hypothesis. If we do X, Y will improve.
Yeah.
You implement it. You collect data to see what happened. Study involving analysis, maybe simple stats like run charts or percentages, and then you act based on those findings. That's applying scientific thinking and data analysis to make improvements, even if it's not publishable research.
So a systematic, data-informed approach is the link. Makes sense. What about the other options? Why are they wrong? B, protocols rather than projects.
It scales backwards, doesn't it? You might use protocols within them, but research studies, QA initiatives, QI efforts, these are definitely structured as projects with aims, timelines, deliverables. They aren't just ongoing protocols themselves.
Okay. C, they don't share systematic investigation.
That's definitely wrong. All three are inherently systematic. Research has its methodology. QA uses structured data collection. QI follows frameworks like PDSA or Lean. They're all about methodical investigation, not just random tinkering.
Right. And D, no IRB approval needed for publication.
That's incorrect, particularly for research. Formal research involving human subjects absolutely requires Institutional Review Board IRB approval before you start, especially if you intend to publish, to protect participants' rights and welfare.
And for QI/QA?
For internal QI or QA, IRB review might not always be mandatory if it's considered part of routine operations and not generalizable research. However, the lines can blur, and ethical considerations are always important. If there's any doubt, or if you might want to publish QI results later, consulting the IRB is the safe and ethical route. So claiming it's not required for publication across the board is false.
Good distinction. Ethics always matter. Okay, question 5. Failure mode and effects analysis, FMEA, is performed A, as a preventative measure before an incident occurs, B, to immediately investigate an incident that occurred, C, if the severity of an incident led to a patient death, D, when there is a chance of an incident reoccurring. FMEA, when do we use this tool?
FMEA is fundamentally about being proactive. So the best answer here is A, it's performed as a preventative measure before something goes wrong.
Before the incident, so it's about looking ahead, trying to anticipate problems.
Exactly. FMEA is a systematic way to look at a process, maybe a new process being designed or an existing high-risk one, and ask, okay, how could this potentially fail? Those are the failure modes.
Right.
Then for each way it could fail, you ask what would be the consequences, the effects, and then you try to estimate how likely is this failure, how severe would the effects be, and how easily could we detect it beforehand.
And that helps you figure out where the biggest risks are.
Precisely. You usually calculate a risk priority number, RPN, based on likelihood, severity, and detectability. That helps you prioritize which potential failures need the most attention, so you can design safeguards or change the process to prevent those failures from ever happening or at least mitigate their effects.
Okay, so it's preventative, proactive. How does that compare to, say, investigating an incident after it happens, like options B and C describe?
That's where you typically use a different tool, most commonly a root cause analysis, or RCA.
RCA.
RCA is reactive. An incident has occurred, maybe a near miss, maybe something serious like option C describes, a patient death, which would trigger an intense RCA, often called a sentinel event investigation. You work backwards to figure out the underlying system failures and contributing factors that allowed the incident to happen.
So FMEA looks forward to prevent, RCA looks backward to learn.
Perfect summary. FMEA was proactive prevention. RCA is reactive learning. Option D, preventing recurrence, is the goal of an RCA, but FMEA's main purpose is preventing the first occurrence by identifying vulnerabilities upfront.
Got it. Very clear distinction. Okay, let's tackle question 6, bringing in some stats again. The relationship between patient satisfaction and hours per patient day on a GOB unit was found to be R, 0.70, P, 0.05. What is the correlation between these two values? A, 0.05 B, most 0.70, C, 14D, 0.49. First, quick clarification, GOB unit.
Yeah, common abbreviation. GOB usually stands for Gynecology and Obstetrics, a women's health unit, typically covering childbirth and related care.
Okay, thanks. Now, the question asks for the correlation. And info gives us R equals 0.70 and P 0.05. So the correlation is?
Well, R is the symbol for the correlation coefficient, so the question gives you the answer directly. The correlation R is 0.70. That's option B.
Okay, seems straightforward if you know R means correlation, but what does that 0.70 actually tell us about satisfaction and staffing hours on this unit?
So the correlation coefficient R measures two things: the strength and the direction of a linear relationship between two variables. The value ranges from -1 to +1. A value close to +1 means a strong positive linear relationship. Close to -1 means a strong negative linear relationship. Close to 0 means a weak or no linear relationship.
And 0.70.
So 0.70 is a pretty strong positive value. It suggests that on this GOB unit, as the hours per patient day, which often reflects staffing levels, go up, patient satisfaction scores also tend to go up. There's a strong positive association.
Higher staffing, higher satisfaction, generally speaking, on this unit.
Got it. And what about the other number they gave us, P 0.05? What's that about?
The p-value. That tells us about statistical significance. A p-value less than 0.05 is a common threshold used in many fields, including healthcare research.
Significance meaning?
It means that the result we observe, this correlation of 0.70, is unlikely to be just due to random chance or fluke in our sample. We can be reasonably confident, typically about 95% confident if p 0.05, that there's a real relationship between these variables in the larger population represented by this unit. It suggests the finding is real and not just random noise. So, strong positive relationship and statistically significant. What about option D, 0.49? Where does that come from?
Good eye. 0.49 is what you get if you square the correlation coefficient R. So 0.70 times 0.70 equals 0.49. This value is called the coefficient of determination, or R squared.
R squared, what does that tell us?
R squared tells you the proportion of the variance in one variable that can be explained or predicted by the variance in the other variable. So in this case, an R squared of 0.49 means that about 49% of the variation we see in patient satisfaction scores on this unit can be statistically associated with the variation in hours per patient day.
So almost half the difference in satisfaction scores is linked to staffing levels.
Statistically linked, yes. And this is crucial. Correlation doesn't prove causation.
Right, you mentioned that.
We see a strong link, but we can't definitively say from this data alone that increasing staffing causes higher satisfaction. There could be other factors involved. Maybe units with higher staffing also have better leadership, or newer facilities, or a different patient mix, But the correlation itself, R, is 0.70.
Important caveat: correlation is not causation. Okay, question 7. When a case manager wants to demonstrate length of stay data that depicts both common cause and special cause variation, which of the following should be used? A, Pareto chart, B, scatter plot, C, Shewhart chart, D, frequency plot. We touched on variation types earlier. Which chart helps distinguish them?
For showing data over time and specifically highlighting the difference between common cause and special cause variation, the go-to tool is the Shewhart chart.
The Shewhart chart, also known as...
The control chart, same thing. Shewhart was the statistician who developed it at Bell Labs way back.
Okay, control chart. What is it about its design that lets us see those two types of variation?
A control chart plots your data points in this case, maybe average length of stay each week or month sequentially over time. Crucially, it adds 3 lines, a center line, usually the average of the data, and 2 control limits, an upper control limit, UCL, and a lower control limit, LCL.
The lines we talked about before.
Exactly. These control limits are calculated statistically from the data itself. They represent the expected range of variation if the process is stable and only subject to common cause variation.
So the normal random fluctuations.
Right. The inherent predictable ups and downs of the process. As long as your data points are bouncing around randomly between the control limits, the process is considered in statistical control. That's common cause variation at play.
And special cause.
Special cause variation is signaled when you see things that are statistically unlikely to happen by chance alone. The most obvious signal is a point falling outside the control limits, either above the UCL or below the LCL.
Okay, a point outside the lines.
That's a big one. But there are other rules too, non-random patterns within the limits that also signal a special cause. Like maybe 7 or 8 points in a row, all trending up or all on one side of the center line. These patterns suggest something specific has changed or influenced the process.
Something beyond the normal background noise.
Exactly. A special or assignable cause. Maybe a new policy was implemented, a key staff member left, a specific type of patient surged. The chart signals that you should investigate why that pattern occurred. It helps you focus your improvement efforts. Don't chase random variation, common cause, but do investigate signals, special cause.
So it separates the signal from the noise. Why wouldn't the other charts work for this? Pareto.
A Pareto chart A is great for prioritization, showing the vital few causes that contribute to most of the problems based on frequency. Think 80-20 rule, but it doesn't show data over time and it doesn't distinguish variation types.
Scatterplot.
Scatterplot B shows the relationship between two different variables, like plotting length of stay against patient age to see if there's a correlation. Again, not for tracking one variable over time, and spotting control issues.
And frequency plot.
A frequency plot D, like a histogram, shows the distribution of the data. How many patients had a 3-day stay, how many 4-day stay, etc. It gives you a snapshot of the spread, but not the time sequence or the stability of the process. Only the control chart does that specific job of showing common versus special cause variation over time.
Makes perfect sense. Control chart it is.
Mm-hmm.
Okay, question 8 takes us to medication safety in pregnancy. In accordance with FDA categorization for medication safety in pregnancy, which statement is true? A, Category A drugs, no evidence of risk reported in humans so far. B, Category B drugs, evidence of risk is only in later trimesters in humans. C, Category C drugs, no risk to the fetus in the first trimester in humans. D, Category X drugs, risk is documented in animals but not in humans. Which one of these descriptions is accurate according to the old FDA categories?
Right. These are the traditional FDA pregnancy categories, A, B, C, D, and X. It's worth noting the FDA has actually transitioned to a newer labeling system, but these categories are still widely referenced and tested. Looking at the options, the statement that is true is A.
A. Category A drugs, no evidence of risk reported in humans so far.
Correct. Category A means that adequate and well-controlled studies in pregnant women have failed to demonstrate a risk to the fetus in the first trimester, and there's no evidence of risk in later trimesters. These are generally considered the safest category, though relatively few drugs fall into it. Think prenatal vitamins, for example.
Okay, so A is the safest based on human studies. Can you give a quick general sense of what the other categories represent, keeping in mind they're broad?
B. Category B is a bit mixed. It generally means either animal reproduction studies have failed to demonstrate a fetal risk and there are no adequate human studies, or animal studies showed a risk, but adequate human studies failed to confirm it. So less certainty than A, but generally considered relatively safe. Many common antibiotics fall here.
Okay, Category C.
Category C is where things get trickier. It usually means animal studies have shown an adverse effect on the fetus, and there are no adequate studies in humans. Or there are no studies in either animals or humans. The drug should only be given if the potential benefit justifies the potential risk to the fetus. A lot of medications end up in Category C due to lack of definitive data.
Benefit versus risk calculation.
Right. Category D, which isn't an option here, but for completeness, means there is positive evidence of human fetal risk based on adverse reaction data or studies, but potential benefits might warrant use despite the risks, for example, for a life-threatening condition.
Okay. And Category X, option D here says risk in animals but not humans.
No, option D gets Category X wrong. Category X means studies in animals or humans have demonstrated fetal abnormalities, or there's positive evidence of human fetal risk, and the risks involved in using the drug in pregnant women clearly outweigh any potential benefits. These drugs are contraindicated in pregnancy. Think drugs like isotretinoin, Accutane, or thalidomide.
Okay, so X is definite risk outweighs benefit, and A is the only one correctly stated in the options. Good to know those distinctions, even with the newer labeling coming in.
Yeah, the principles behind them are still relevant for understanding risk assessment. The new system, the PLLR, Pregnancy and Lactation Labeling Rule, aims to provide more narrative detail and context, which is definitely an improvement.
More nuance. Okay, question 9 deals with team dynamics and conflict. The leader of a quality improvement team needs to deal effectively with a conflict between two units. It is best to appoint which of the following to his membership? A, a human resources representative. B, a facilitator. C, a risk manager. D, a senior safety officer. Conflict resolution on a team. Who do you bring in?
When you have inter-unit conflict cropping up within a QI team, the most direct and helpful addition is usually be a facilitator.
A facilitator. Why them specifically? What skills do they bring to this kind of situation?
A good facilitator is skilled in managing group dynamics, communication, and specifically conflict resolution. Their role isn't to take sides or impose a solution, but to guide the process.
Guide the process.
How? They help ensure everyone gets heard respectfully. They can help the team define the conflict clearly, explore the different perspectives and underlying interests, keep the discussion focused and productive, and guide the group towards finding common ground and developing their own mutually agreeable solutions. They're neutral process experts.
So they help the team navigate the conflict themselves, rather than solving it for them.
Exactly. They empower the team to resolve its own issues, which is often more sustainable.
Makes sense. What about the other roles? HR Rep A?
An HR representative might get involved if the conflict escalates into, say, harassment or formal complaints between individuals. But for resolving operational or process-related conflict between units within a QI project, their role is usually less direct than a facilitator focused on team function.
Risk Manager.
The risk manager is focused on patient safety and organizational liability. They might be interested in the impact of the conflict if it's creating risks, but they aren't typically trained mediators for team disputes themselves. They might be a stakeholder or provide input, but not usually the conflict resolver.
And the Senior Safety Officer D.
Similar to the risk manager, their focus is on safety systems and protocols. Important perspective, perhaps, but not the primary skill set for mediating inter-unit disagreements on a QI team. The facilitator brings that specific expertise in group process and conflict navigation.
Right. Tool for the job, facilitator it is. Okay, question 10 brings us back to descriptive stats. Which one piece of information is the most useful to describe the age of population that is served in an anticoagulation monitoring service clinic? A t-test, B mean C. Standard error of the mean, SEMD square test. Just one number to give a sense of the typical age.
For a single, easily understood measure of the central tendency of a continuous variable like age, the most useful piece of information is B, the mean.
The mean, or the average, why is that the most useful single descriptor here?
Because it gives you a quick snapshot of the center of the age distribution for that clinic's patients. If the mean age is, say, 72, you immediately get a picture of a predominantly older patient population. If the mean age was 45, that tells a very different story about who the clinic serves and what their potential needs might be. It's a simple, intuitive summary statistic.
Provides a quick reference point. Okay, why aren't the others as useful for this specific purpose describing the typical age? T-test, A.
A t-test isn't a descriptive statistic for one group. It's an inferential statistic used to compare the means of two different groups. Like comparing the average age of patients in this clinic versus another clinic, or comparing ages before and after an intervention. It doesn't describe the age of this population itself.
Okay. Standard error of the mean, SEMC.
The sum is related to the mean, but it measures the precision of our sample mean as an estimate of the true population mean. A smaller sum means our sample average is likely very close to the actual average age of all possible patients the clinic could serve. It's about confidence in the estimate, not the estimate itself. It doesn't tell you the typical age directly.
So it's more about reliability of the average.
Right. And the chi-square test, D. Chi-square is used for analyzing relationships between categorical variables. Things like, is there an association between the type of insurance a patient has, category, and whether they adhere to their appointments category. It's not used for describing a single continuous variable like age.
So for that single snapshot of how old are these patients typically, the mean is the most direct answer.
Yep. While other measures like median, the middle value, and standard deviation, the spread, are also very useful for describing the age distribution more fully, if you have to pick one piece of information, the mean is usually the most informative single descriptor of the center.
Got it. Let's keep rolling. Question 11. The primary goal of risk management is to A, minimize financial loss associated with legal actions. B, perform failure mode and effects analyses, FMEA. C, maintain an effective and timely incident reporting system. D, identify the high-risk areas of the organization. What's the main objective, the big picture goal? of risk management in healthcare?
This is a good one because all those options are things risk managers do. But the primary goal, the starting point for everything else, is D, identify the high-risk areas of the organization.
Identify the risks first. Why is that the foundational goal?
Because you can't effectively manage risks you don't know you have. Identifying where the greatest potential for harm to patients, staff, or the organization itself exists allows you to be strategic. You figure out where your biggest vulnerabilities are, whether it's medication errors in a certain unit, surgical site infections for specific procedures, patient falls in particular areas, or even financial or reputational risks.
So you know where to focus your attention.
Exactly. Once you've identified those high-risk areas, then you can implement strategies to address them. That might involve actions to minimize financial loss, like improving documentation or processes to reduce liability. It might involve using tools like FMEA, specifically on those high-risk processes you identified. And it certainly involves ensuring your incident reporting system, C, is robust, especially for capturing events or near misses in those high-risk areas. But the identification comes first. It drives the entire strategy.
It's proactive, not just reactive. Find the weak spots before they cause major problems.
That's the ideal, yes. Risk management aims to be prospective anticipating and mitigating risks, as well as retrospective learning from incidents that do occur. But the foundation is knowing where to look.
Makes sense. Identify, then act. Okay, question 12 moves to patient education. A 67-year-old diabetic patient being taught how to self-administer insulin. Which of the following is the best method to assess this patient's understanding of the teaching? A, patient satisfaction survey. B, return demonstration. C, family's ability to verbalize instructions. D, written pre- and post-test.
How do we really know if this patient can do the injection correctly?
For a hands-on psychomotor skill like injecting insulin, the gold standard for assessing competency is absolutely B, return demonstration.
Return demonstration.
Yeah.
So having the patient actually show you.
Yes. You teach them the steps, then you have them show you how they would do it, using maybe a practice pad or an orange, and talking you through the steps as they go.
Why is that so much better than the other options? Because it directly assesses their ability to perform the task safely and correctly. You can see if they're drawing up the right dose, choosing the correct site, using proper technique, disposing of the needle safely. It tests not just their knowledge, but their physical skill and their understanding and practice. You can catch errors and correct them immediately.
Right, you see it happen. What about the others? Patient satisfaction survey. A.
A survey tells you if the patient liked the teaching or felt the nurse was clear. It doesn't tell you if they actually learned how to do it. They could be very satisfied, but still completely misunderstand a critical step.
Okay. Family verbalizing instructions. C.
Involving family is often good for support, yes, but the patient is the one self-administering. Assessing the family's understanding doesn't guarantee the patient understands or can do it. We need to assess the individual performing the task.
And the written test. D. Pre- and post-test.
A written test can check their cognitive knowledge. Do they know why they need insulin, what the signs of low blood sugar are, the names of the steps? That's important context. But it doesn't assess their ability to physically draw up and inject the insulin correctly. Someone could ace the written test, but be completely unable to perform the procedure safely. For skills, you need to see the skill performed.
Teach back for knowledge, show back for skills.
Exactly. Return demonstration is the show back part, and it's critical for procedures like this.
Makes total sense. Okay, question 13, a more conceptual one about quality itself. All of the following are key aspects of quality except TA. It depends upon customer perceptions. B, it does not change with time. C, it considers customers' needs. D, it promotes high levels of precision. Which one of these doesn't fit the modern understanding of quality?
The statement that is definitely not true about quality is B. It does not change with time.
Quality changes over time. Why is that the case?
Absolutely it changes. Think about it. Customer expectations evolve. What was considered a luxury feature yesterday might be standard today. Technology advances, creating new possibilities for safety and effectiveness. Research discovers better ways to provide care. Regulatory standards get updated.
So the benchmark is always moving.
Exactly. Quality is a dynamic concept, not a static endpoint. What constituted high-quality care for, say, a heart attack 20 years ago is very different from the evidence-based standards of care today. Organizations committed to quality have to be constantly learning, adapting, and improving just to keep pace, let alone lead. So the idea that quality is fixed is completely counter to the principle of continuous quality improvement.
Right. CQI implies quality can and should change for the better. So B is out. Why are the others considered key aspects? A, depends on customer perceptions.
Hugely important. While we have objective measures of quality, like mortality rates or infection rates, the perceived quality from the customer's viewpoint, often the patient and family in healthcare, is critical. Did they feel cared for? Were their needs met? Was communication clear? Their perception is part of the quality equation. Often, quality is defined as meeting or exceeding customer expectations.
C considers customer needs.
Directly related to A, you can't meet expectations if you don't understand the needs. High-quality care is patient-centered. It actively seeks to understand and address the patient's clinical needs, personal preferences, values, and concerns.
And D promotes high levels of precision.
Yes, precision, accuracy, reliability, minimizing errors. These are fundamental to technical quality and safety. Whether it's administering the correct medication dose, performing a surgical procedure accurately, or ensuring diagnostic tests are reliable, reducing unwanted variation and striving for precision are hallmarks of high-quality processes.
So, quality is precise, meets customer needs and perceptions, and is always evolving. Got it. Question 14 looks at synthesizing research. Regarding meta-analysis, all the following statements are true, except TA. It is a statistical procedure that integrates the results of several independent studies that consider to be combinable. B, it doesn't allow a more objective appraisal of the evidence than traditional narrative reviews. C, it provides a more precise estimate of a treatment effect. D, it may be biased due to exclusion of relevant studies or inclusion of inadequate studies. Which statement about meta-analysis is false?
The false statement here is B. It claims meta-analysis doesn't allow a more objective appraisal than traditional narrative reviews. That's the opposite of its intent.
So meta-analysis is actually supposed to be more objective. How does it achieve that?
Well, a traditional narrative review relies heavily on the reviewer's expertise to select studies, interpret their findings, and weave them into a coherent story. There's inherently some subjectivity in that process, which studies get highlighted, how conflicting results are weighed.
Right. Different reviewers might reach different conclusions from the same body of literature.
Exactly. Meta-analysis tries to minimize that subjectivity by using a predefined, systematic process. You set clear criteria for which studies to include, you extract the quantitative results, like effect sizes, from each eligible study in a standardized way, and then you use statistical methods to pool those results together.
Combining the numbers from multiple studies.
Right. It generates a summary statistic, like an overall estimate of a treatment's effectiveness, based on all the combined evidence that met the criteria. This quantitative synthesis is generally considered more objective and less prone to individual reviewer bias than a purely narrative approach.
Okay, so B is definitely false. Meta-analysis aims for more objectivity. Let's confirm the others are true. A, statistical procedure integrating combinable studies.
Yep, that's the definition. Statement A is true. You need the studies to be similar enough in terms of patients, interventions, and outcomes measured to be statistically combinable.
C provides a more precise estimate of effect.
Generally true. By pooling data from multiple studies, you effectively increase the overall sample size. Larger sample sizes usually lead to narrower confidence intervals around the effect estimate, meaning a more precise estimate of the true effect. So C is true.
And D can be biased by study exclusion or inclusion.
Also true, and a very important limitation to be aware of. Meta-analyses are susceptible to publication bias. If studies with negative or null results are less likely to be published, the meta-analysis might overestimate an effect because it's only pooling the positive published studies.
So unpublished studies are missing.
Right. And conversely, if the meta-analysis includes poorly designed or conducted studies, garbage in, garbage out, that can also bias the results. So while it aims for objectivity, the quality of a meta-analysis depends heavily on the thoroughness of the search for studies and the critical appraisal of the studies included. D is a true cautionary statement.
Good to remember. Even powerful tools have limitations. Okay, question 15, back to variation. The following are reasonable descriptions of variation in process capability. Except A, extent to which process conforms to the norm, EB, distance from perfection. C, degree of distribution about the mean. D, antithesis of quality. Which description doesn't quite fit how we think about variation in quality?
This ties back to our earlier chat. The one that's not quite right is D, antithesis of quality.
Variation isn't the opposite of quality. Why not? Seems like less variation would be better.
Well, less unwanted variation is usually better, yes. But variation itself is inherent in every process. Nothing is perfectly identical every single time. Think about commute times, patient waiting times, even the exact dimensions of manufactured parts. There's always some natural fluctuation.
The common cause variation we talked about.
Exactly. Quality management isn't about eliminating variation entirely because that's impossible. It's about understanding the variation, distinguishing common cause from special cause, and reducing variation where it matters to consistently meet customer requirements.
So variation exists. Quality is about managing it appropriately.
Right. You could have a process with very little variation, but it's consistently producing results that are way off target or don't meet customer needs. Low variation, but still poor quality in that sense. Conversely, a process might have some variation but still be well within acceptable limits. So variation isn't the antithesis of quality. It's a characteristic of processes that quality management seeks to understand and control appropriately.
Okay, that nuance is important. What about the other descriptions? A, extent of conformance to the norm.
That fits. Process capability often involves measuring how well the process output stays within specified limits or conforms to expected norms. High variation might mean poor conformance.
B, distance from perfection.
Also reasonable. Variation contributes to the gap between actual performance and the ideal target or perfection. Reducing variation often helps get closer to the target consistently.
And C, degree of distribution about the mean.
That's a very direct statistical description of variation. Measures like standard deviation or variance quantify exactly how spread out the data is around the average. So A, B, and C are all reasonable ways to think about or measure variation in relation to process capability. D is the outlier because it presents an overly simplistic negative view.
Got it. Variation is a feature, not necessarily a bug, that needs management. Question 16 is about the structure of scientific references. Published articles, information, and scientific journals is set in the following sequence. A, title, authors, journal, year, volume, issue, page S. B, journal, year, volume, issue, page S. C, author, journal, year, volume, issue, page S, which is the standard citation format.
Citation formats. There are minor variations between styles like APA, AMA, MLA, etc., but the most common and logical sequence for finding an article is C.
C, author, title, journal, year, volume, issue, pages. Why is this the standard order?
It generally follows a logical flow for identification. You start with who did the work, authors, then what the work is about, title, then where it was published, journal name, when it was published, year, and finally the specific location within that journal, volume, issue, pages.
Kind of helps you track it down efficiently.
Exactly. If you're searching a database, you often start with author or keywords from the title. Knowing the journal tells you where to look next. The year gives context, and the volume issue pages pinpoint the exact article. The other options mix this up illogically. For instance, putting the journal first, B, or separating the author and title D is less standard.
Okay, C follows the most common pattern for finding the source. Good to know. Now, question 17 presents a scenario. Your community hospital has coordinated with local municipality authority to convert a busy intersection to a roundabout, i.e. traffic circle, to alleviate long-standing congestion. But after completion, it was realized that large fire trucks cannot fit through the new configuration. This is an example of A, quality assurance, B, unintended consequences, C, continuous quality improvement, D, system reengineering. What concept does this story illustrate?
Oh dear, that's a classic and rather unfortunate example of B, unintended consequences.
Unintended consequences. Seems obvious, but break it down. Why does it fit so well?
The intention of the roundabout was positive,
Mm-hmm.
improve traffic flow, probably enhance safety compared to a traditional intersection. That was the goal.
Right. Solve the congestion problem.
But in achieving that goal, they inadvertently created a new problem that wasn't foreseen or planned for the large emergency vehicles. Can't use it. This negative outcome stems directly from the initial action, building the roundabout, but was not the desired or expected result. That's the essence of an unintended consequence. It's a side effect, often negative, that wasn't part of the plan.
Happens more often than we'd like, probably. Why aren't the other options the best description? Quality assurance, A.
Quality assurance is about processes to ensure something meets predefined standards or specifications. Maybe the roundabout was built exactly according to the plans QA passed, but the plans themselves were flawed because they didn't account for fire truck clearance. So QA isn't the core issue here. The unforeseen functional problem is
Continuous quality improvement, C.
Well, this situation would certainly trigger a CQI effort now. They'll need to figure out how to fix the roundabout or find alternative routes. But the event itself, realizing the trucks don't fit, isn't CQI. It's the problem that CQI needs to address.
And system reengineering.
System reengineering usually implies a more radical, fundamental redesign of a whole process or system. Building one roundabout might be part of a larger traffic system change, but the term unintended consequences specifically captures the nature of this particular outcome, the unforeseen negative side effect of a specific change. It's the most precise fit.
Got it. A well-intentioned change with a surprise negative outcome. Okay, question 18 tests knowledge about key quality organizations. All of the following statements are true, except TA. Accreditation by the Joint Commission is mandatory for hospitals that bill Medicare for services. B. The Institute for Healthcare Improvement is an independent, nonprofit organization promoting patient safety initiatives. C. The National Quality Forum reviews and endorses voluntary consensus standards. D. The Hospital Quality Alliance develops and promotes the utilization of quality measures, such as those addressing surgical wound infections. Which statement is incorrect?
The incorrect statement here is A.
A. Accreditation by the Joint Commission is mandatory for hospitals billing Medicare. That's not true. I thought TJT accreditation was essential for Medicare participation.
It's very common, and for a long time it was the dominant pathway, but it's not strictly mandatory. The key concept is deemed status. CMS, the Centers for Medicare and Medicaid Services, has deemed certain accrediting organizations to have standards that meet or exceed Medicare's own conditions of participation. COPS. So if a hospital achieves accreditation from a CMS-approved accrediting organization like the Joint Commission, but also others like DNV, Det Norsk Veritas, or HFAP, Healthcare Facilities Accreditation Program, then CMS deems that hospital to meet the COPS.
So TJC is one option for deemed status, but not the only option.
Exactly. Alternatively, a hospital could forego accreditation by one of these bodies and instead demonstrate compliance directly through surveys conducted by state survey agencies on behalf of CMS. That's less common for hospitals, but it's possible. So, Statement A, saying TJC accreditation is mandatory, is false. Deemed status through an approved accreditor, which includes TJC, or direct state survey compliance is required.
That's a critical distinction. Good clarification. Let's quickly verify the others. B. IHI is independent nonprofit for patient safety.
Yes, that's correct. The Institute for Healthcare Improvement, IHI, is a very influential independent organization focused on safety and quality improvement globally, known for things like the 100,000 Lives campaign and lots of improvement methodologies. B is true.
C. NQF endorses consensus standards.
Also true. The National Quality Forum, NQF, plays a crucial role in the U.S. by bringing stakeholders together to reach consensus on and endorse standardized performance measures for quality reporting and improvement. NQF endorsement is often a key factor for measures used in public reporting and payment programs. C is true.
In D, Hospital Quality Alliance promoted quality measures like SSI.
Yes, the HQA, which was a public-private collaboration, was instrumental in aligning hospitals, government agencies, and others around using a standardized set of quality measures, including process and outcome measures like those for surgical site infections, SSI, heart attack care, etc., to drive transparency and improvement. So D is also true.
Okay, so A is definitely the incorrect statement. Good to know the players. Question 19 is about teamwork. A team approach to assist in problem solving is most useful when A, diverse areas of expertise are required, B, the organization's goals are unclear, C, communication challenges exist, D, there are adequate resources within the organization. When does using a team really shine for problem solving?
Teams can be useful in many situations, but their unique strength often comes out most strongly when A, diverse areas of expertise are required.
Diverse expertise. Why is that the sweet spot for teamwork?
Because complex problems, especially in healthcare, rarely live neatly within one department or discipline. Think about reducing hospital-acquired infections, improving patient flow, or implementing a new electronic health record. These challenges touch nursing, physicians, pharmacy, IT, administration, environmental services, patients, you name it.
Right, they cut across silos.
Exactly. No single person or single department has all the knowledge, perspectives, or understanding of the interdependencies needed to fully analyze the problem and develop effective, workable solutions. Bringing together people with those different viewpoints and expertise allows the team to see the whole system, identify leverage points, anticipate potential barriers, and generate more robust and creative solutions than any individual could alone. It's the synergy of different perspectives.
leveraging collective intelligence. What about the other scenarios? B, unclear goals.
A team might be formed to help clarify unclear goals. B, that's true. But the primary usefulness in problem solving itself isn't necessarily driven by unclear goals. It's driven by the complexity needing multiple viewpoints. Clarifying goals might be a problem the team tackles.
C, communication challenges.
Similar to B. Forming a cross-functional team can definitely help address existing communication challenges. C, by forcing people from different areas to talk to each other. But again, the fundamental value of the team approach in solving the underlying problem often lies in the diverse knowledge needed, not just the act of communicating itself, though communication is vital for the team to work.
And D, adequate resources.
Adequate resources, D, are necessary for any problem-solving effort to succeed, whether by an individual or a team. It's an enabler, not the reason why a team approach is specifically useful. You need resources, but the reason you form the team is often the need for that diverse expertise.
So the core advantage is tackling complexity through multiple lenses. Makes sense. Okay, our 20th question for this stretch, returning to variation. All of the following statements about variation in quality management methods are true, except TA. Special cause variation is best addressed at the specific source. B, special cause variation is typically random in nature. C, common cause variation is also known as internal variation. D, common cause variation is inherent to any given process. Which statement about variation gets it wrong?
We've circled back to this nicely. The incorrect statement here is B. Special cause variation is typically random in nature.
Special cause variation is not random.
Correct. It's the opposite, actually. Special cause variation is, by definition, non-random. It's variation that arises because of specific, identifiable, assignable causes that are not part of the process's usual functioning.
Like the examples you gave earlier, a machine malfunction, a policy change, a sudden shift in patient acuity.
Exactly. These are specific events or factors that perturb the system and cause deviations or patterns that wouldn't occur just by chance under normal operating conditions. Because it's non-random and has a specific cause, it's often possible and desirable to investigate and eliminate or control that cause.
Okay, so B is definitely false. Let's check the others. A, special cause variation best addressed at the source.
True. Since it has a specific assignable cause, the most effective way to deal with it is to find that cause and address it directly. Putting a Band-Aid elsewhere won't fix the underlying issue. So A is true.
C, common cause variation, also known as internal variation.
Yes, that's a common synonym. Common cause variation reflects the variability that's built into the current process or system itself, the internal or inherent fluctuations. So C is true.
And D, common cause variation is inherent to any given process.
Also true. As we discussed, every process has some level of natural random fluctuation due to the multitude of small, uncontrolled factors always at play. That's the inherent common cause variation. You can't eliminate it entirely, but you might be able to reduce it by fundamentally improving the process itself. So D is true.
Okay, so special cause is non-random and assignable. Common cause is random and inherent. B got it backwards.
Precisely.
Phew. All right, that's our first block of 20 questions. We've covered quite a spectrum: leadership, patient experience, data interpretation, quality tools like FMEA and control charts, medication safety, team dynamics, core quality concepts, research methods.
It's a good sampling of the breadth of CPHQ topics.
Yeah.
Hopefully, digging into the why behind the answers is helping solidify these concepts for you, the listener.
Absolutely. The goal isn't just to get the answer right, but to really understand the principle being tested. That's what makes the knowledge usable, right?
Exactly. It's about building that deeper understanding you can apply in different situations.
So as we take a brief pause, perhaps, think about these concepts. Remember that distinction between common and special cause variation. That's huge. Understanding why leadership involvement is critical, not just that it is, seeing how different tools fit different purposes.
And don't forget the importance of the customer perspective and the fact that quality is always evolving. It's a journey, not a destination.
Well said. We've got many more questions to tackle in this deep dive. Ready to continue?
Let's do it.